Hi, good afternoon, good morning if you're in California, where our award winners are. Welcome to the 2021 Asthma Winners Webinar, Addressing Asthma Disparities and Health Inequities in Communities. My name is Tracy Mitchell, and I'm with EPA's Indoor Environments Division. EPA is really pleased to be here with you today during Asthma Awareness Month to bring you this informative webinar. Thank you all for being with us. We have two very impressive asthma programs who will share their award-winning strategies with you in just a few moments. First, I'd like to just take care of a couple housekeeping tips. All attendees will be muted for the entire webinar. If you do have questions, we invite you to submit them in the chat function on the screen. Any questions that are submitted will be then transported to AsthmaCommunityNetwork.org, where we'll hold our question and answer session live from 3 to 3:30 p.m. Eastern Time. So please, if you're not already a member of AsthmaCommunityNetwork.org, you see on the screen, there's information and directions there for you to join Asthma Community Network. If you are a member, you'll need to log in, and then you'll go to the tab that says Discussion Forum. You'll see today's date, and you can click on that, and then you'll be able to submit your questions. This is where you'll be able to interact with our award winners, again, from 3 to 3:30, immediately after the webinar. And this is also where the questions and answers will be archived for your convenience to be able to go back and reference them and continue the learning. So I'll just give it another second if folks are trying to figure out how to log in. But speaking of the learning, let's go to our learning objectives for today. Today you'll hear from our award winners, the 2021 National Environmental Leadership Award and Asthma Management winners. They'll talk about their successful strategies for effective in-home interventions and how they're doing that through in-home visits and virtual visits during COVID, how they've been able to successfully pivot and conduct virtual home visits. We're also going to learn from them about building partnerships in their communities and to help address disparities and health inequity. And we'll discover strategies on sustainability and reimbursement, especially through Medicaid and health plans and other options. As I said, my name is Tracy Mitchell. I'm with EPA's Indoor Environments Division in Washington, D.C. I'm a respiratory therapist and a certified asthma educator, and so I'm greatly honored to be here as your moderator today with our speakers. I'd like to introduce them at this point and tell you a little bit about who you'll be hearing from today. First, from Central California Asthma Collaborative, our first winner is Kevin Hamilton. Kevin is focused on reducing the burden of chronic respiratory disease and environmental health impacts in the San Joaquin Valley. He has served as developer, coordinator, administrator, director, kind of every role you can imagine for multiple programs in the hospital and community-based settings, serving poor and underserved communities in the San Joaquin Valley. His education includes an associate degree in respiratory therapy, fellow respiratory therapist, and a Bachelor of Science degree in geology, as well as extended coursework in social work, mathematics, business, and management. He has worked extensively on different aspects of healthcare access and redesign around primary care, disease management, behavioral health for more than 35 years. He's a well-known advocate for social and environmental justice, and we are thrilled to have him here with us today. From Rady Children's Hospital in San Diego, we'll hear from Dr. Carrie Carstairs, who serves as the Chief Population Health Officer at Rady Children's. She also serves as faculty at University of California, San Diego, Department of Pediatrics. Dr. Carstairs is board certified in emergency medicine and pediatric emergency medicine. After earning her degree from Tulane University, she served 13 years in the U.S. Navy as an emergency physician, before joining the faculty at Rady Children's Hospital. Dr. Carstairs' research interests include healthcare systems and outcomes research, including reducing the variation in care and associated improvement in delivery of healthcare. So we're very excited to have her with us today, and thank you for your service, Dr. Carstairs in the Navy. So now we've met our speakers. Before we dive in, I'd like to hear and meet our audience. So if you'll just take a moment to answer our polling question, please choose what sort of organization you represent. Is it a government agency? Are you primarily a healthcare provider? Do you work for a health plan? Are you a community-based organization or other? We'll go ahead and just give it about 30 seconds for folks to choose their organization. Okay, go ahead and close the poll. Great, so we have, looks like many from the federal government. We have a large group of people from community-based organizations, a few from health plans, and a good number of healthcare providers. So thank you all for being here. I think regardless of what organization you represent, you'll find this information useful and helpful. So thanks again. Let's go ahead to the next slide. So before we learn and hear from our winners, I just want to talk a minute about the actual award. EPA's unique contribution to the national asthma effort is this awards program. This is the highest recognition in the country that a program can receive for delivering excellence in environmental asthma management as part of comprehensive care. So this annual competition surfaces programs and their successful approaches at the community level. And the review of application really brings together our federal family. EPA, CDC, HUD, and NIH really gather and come to consensus regarding the best practices in asthma care, again, based on guidelines-based care. The award specifically, I just want to talk a little bit about what these programs went through to apply, and in hopes that maybe folks listening will be considering applying in the future. So the application, which lives on AsthmaCommunityNetwork.org, really has three main components. The first component is comprehensive asthma management, and this is really broken down into three subcategories. We talk about management and operations, where the applicant is asked to describe the history of their program, kind of the mission and leadership role. 1B is the integrated health services. And so we know that it's really a comprehensive approach. And here's where we ask applicants to describe their community's integrated asthma care, including partners and different roles that those partners serve, and coordinating comprehensive care. This is the Environmental Leadership Award, so the real meat of the award is the tailored environmental services portion. We ask applicants to share how they're addressing indoor and outdoor environmental triggers and how they ensure that the care is integrated and tailored across the continuum of care. Applicants are asked to describe who's delivering services, especially in-home services like assessments and remediation. Then the second category is about getting results and evaluation. And so obviously we know it's important to be able to demonstrate that our work is having an impact and getting results. So this section is where we ask applicants to really discuss the measures that their programs track and the health outcomes that they're getting and the cost savings that they're achieving. And then lastly, the third component is about sustainability. And here we're asking applicants to describe their current and long-term funding sources, revenue streams, and arrangements to help ensure that their services and their program continues to be able to provide services. So in talking about the application, really the application highlights or mirrors EPA's system for delivering high-quality asthma care, which features essential components to delivering effective and sustainable programs. So you see this kind of conceptual framework, and And it's really based on the results of the Asthma Health Outcomes Project, which was conducted by the University of Michigan several years ago. And in that project, they identified the core elements of a successful asthma program, and then the processes that drive implementation, continuous improvement, and endurance. So I invite you to listen today to our winners as they describe their programs and listen for the components that you see here on the screen. Those key drivers in the middle, the strong community ties, the integrated services, and the tailored environmental interventions. You'll hear how their programs were built, how they started, the results they're getting, and how they're using those results to sustain and grow their programs. Just very quickly, I want to welcome our 2 award winners to the Hall of Fame officially. You see here about half of the 50 previous winners that are in the Hall of Fame on Asthma Community Network. And these really represent the best healthcare providers, health plans, and community programs across the country. We are excited that once receiving the award, winners become part of our dynamic network and serve as mentors to other programs, as well as faculty to help spread best practices. And each year we feature our award winners on a national webinar, as we're doing today. So I invite you to access, again, Asthma Community Network, where previous webinars are archived, and where you can also read program profiles about each of our award winners. This is just another look at the Hall of Fame and the 50 award winners. And so you'll see where the programs are located across the country. And maybe coincidentally, maybe not, both programs this year are from California. There's a lot of great work we know happening in California, especially around sustainable financing of in-home services. But it really doesn't matter if there's a winner in your state or even in your region. Through AsthmaCommunityNetwork.org, you can request a mentor, and we will work to match you up with a program, a previous winner, who can help you if you're trying to tackle a specific issue or just need some guidance in a certain area. So we'll be happy to help you identify a mentor, and these programs really are happy to serve in that role, to share information, expertise, and their experience in order to help your program and in your community. So I don't want to spend a lot of time on this because I don't need to tell this audience, but I think I just want to remind everyone we know asthma is a public health challenge that is characterized by disparities. The prevalence remains particularly high in children and minorities and children living in poverty. And so both of our award winners, Central California Asthma Collaborative and Rady Children's Hospital, they know this too well. These are the communities they're serving. And they know that these are the kids that end up with high utilization, hospitalizations, and emergency department visits. But they know that they are able to do something about it. And you're going to see that today and hear how they are having a real impact on healthcare utilization. We also know that the environment plays a significant role in asthma, and comprehensive care is essential for getting asthma under control. There's been progress made over the last several years, but really there's still a critical need for solutions focused at the state and community level. We know asthma is an expensive disease, over $50 billion each year. And we know Medicaid spends over $10 billion annually to treat children and adults with asthma. But we also know that delivering in-home environmental services, remediation and interventions helps to reduce those costs, helps to increase savings, and expands healthcare, the healthcare workforce. We also know at EPA, science is the foundation of our program, and we know that that we can really have an impact on triggers in folks' homes by doing these in-home interventions, by conducting in-home interventions, and especially focusing on common asthma triggers, things like tobacco smoke, pet dander, molds, cockroaches, and dust mites. We know that we can see results in reduced symptoms and reduced hospitalizations, improved health outcomes. We also know that for high-risk populations, that it's really important to bring these services to them. And you'll hear that from our award winners as well. EPA, as the technical experts on the built environment and health, has really led the federal effort through non-regulatory strategies to enable communities to deliver and sustain in-home environmental care. And we are aimed at ensuring access to that care and closing the health equity gap one community at a time. So my last slide, how is EPA doing this? I just want to highlight a couple of things very quickly. First, we're hosting learning spaces like AsthmaCommunityNetwork.org, and I've mentioned it probably almost a dozen times, but hopefully you are a member. This is where you can share, learn, and connect with other programs, over 1,000 programs across the country. We provide technical assistance through our cooperative agreements and partnerships. We're highlighting the award winners and leveraging their excellence. But we're also working on the national level with our federal partners in the Asthma Disparities Working Group to advance policy nationally as well as regionally and locally. And finally, we synthesize and spread the learning in a variety of ways, and that's what we're here to do today on today's webinar. By shining a spotlight on these two stellar programs, we're here to accelerate the learning and adoption of best practices. So without further ado, I'll turn it over to our first speaker, Kevin Hamilton from Central California Asthma Collaborative. Thank you.
Good morning, and thank you for having us here today. Again, my name is Kevin Hamilton, and I lead the Central California Asthma Collaborative. This is Graciela Dinez. She is the manager for the Asthma Impact Model Program here at CCAC. So as you can see, we have a multi-component intervention strategy that's based on NHLBI, NIH, NAEPP guidelines, I think, as most of our successful programs are. We provide all these different services that I think, again, are pretty standard in our particular area of expertise, which is in-home environmental evaluations, of course, health education. This is a health education program. Case management, which is critical to the work that we do. Our staff are case managers. They work with patients in all kinds of areas to bring assets to them and not just hand them applications to fill out or phone numbers to call, but actually manage those particular applications with the patient to ensure that they're successful. And then, of course, constantly testing ourselves and doing utilization review on our own work. And our patients. So we're lucky enough to partner with local managed care organizations. This took years to develop those relationships, and local providers and community health centers. Things that we track: health outcomes, the cost of providing this service, which is critical in today's world of thin dollars in the healthcare sector for reimbursement, and then, of course, the policy implications. And we work to develop specific policy goals around sustainability. So these are our patients. This is one of our families. Obviously, we consent everybody to have their picture shared, and we serve mainly low-income, disadvantaged communities of color across California's San Joaquin Valley. The San Joaquin Valley, for those of you who don't know it, was once coined to be the Appalachia of the West. The average poverty rate here runs around 40% of the population. Almost 100% of the children in the San Joaquin Valley are on free or reduced lunches in their schools. There's over 4.4 million people living in the San Joaquin Valley, and we're based in Fresno, California, which has a population of just over 600,000 people, and the county is just over 1 million people large. In other parts of the country, we'd be a major metropolitan area, and we are. In California, we kind of disappear into the background of Los Angeles and the Bay Area. All of our patients are either on Medi-Cal or uninsured, and of course, they suffer from asthma. Our current population is predominantly Latinx, Hispanic, and African American, mainly children. But we see adults as well. Our oldest patient, I believe, right now is probably 88 or 87 years old. So it's important to know why we do this. Prevalence rates here in the Valley are very high. As you can see, California's rate is at 15% as of 2017. California Department of Public Health set up a division called California Breathing that actually tracks this data through claims and other vehicles. In Fresno, where we're sitting right now, the rate is 18%. Kern has the highest rate, and Kern is also a center not just for major agriculture, predominantly dairies and growing almonds, but also the highest intensity of oil and gas infrastructure in the Western United States. Again, I mentioned the valley's 270 miles long and 70 miles wide. We serve 5 out of the 8 counties. So our program puts these really amazing, this is the AIM team, by the way, puts our trained allied health professionals right in the homes of our patients. We believe strongly that healthcare belongs in the home as much as possible. One of the things that we say a lot is that who takes care of the patient? Well, actually the patient or the patient's parents take care of the patient. The doctor sees them and the healthcare system sees them less than 24 hours a year. The rest of the time they have to take care of themselves. So where should we provide the support for them to do that? Should be in the place they're most comfortable, which hopefully is their home. All of our community health workers have graduated from an accredited public health program or have another health focus degree. They are from and or live in the communities in which they work and serve. And this health education and environmental intervention, as I mentioned, are delivered in the home. We provide environmental remediation, such as air filters, carpet cleanings, a number of other things, connecting them to weatherization programs and energy efficiency programs to put range hoods over gas stoves where people have pulled their electric stove because they feel natural gas is cheaper, but never bothered to put in a range hood. Repairing vent fans in bathrooms to make sure there's no mold growing in there. Things like this are pretty standard fare for us. So COVID-19, man, wasn't that something? Isn't it something? And for us, it was a major event, not just because of the impact on our community and our staff. The patients that we had still had to be taken care of, and new patients keep coming. So we were forced on a very quick pace, and fortunately lucky enough to have the technical expertise in-house to be able to very quickly, within a month, come together, create a policy and procedure, update our data security, create new policies for that, and contract with WebEx and DocuSign, which both could provide us with HIPAA certificates, which is critical as we need to protect that private health information. And we were up and running in about 29, 30 days from the time we started working on it to the time we saw our first patient. And that was April 6th, as you can see, 2020. So I think everybody remembers it was March when the original quarantine was put in place. So we were moving very quickly. We were lucky enough to catch the attention of the California Department of Public Health. And in May, they recognized our virtual visit model as a best practice. And in June, we did a statewide webinar. Everything we do is open source. So we're happy to share all of those tools with anybody who would like to have them. And at that point, we had 143 folks attending, which was a real honor. How do we know that this program works? Well, we track a lot of data. And since we work with health plans, we're able to get data that's up to date. Prior to that, we had to work with a local university under contract because we are a community-based organization. We are not sponsored by a hospital. We do not live inside a hospital or work with a hospital directly or a clinic as a program or department of a clinic. We are a freestanding 501c3 community-based organization. But in a randomized control study that we had done that was funded by the California Endowment, we were able to demonstrate a 70% decrease in asthma-related hospitalizations. And you can see the decrease in emergency room visits and unplanned outpatient visits. But the number that we tracked that was most important to us, quite honestly, was the increased well visits, preventative care visits. We need our patients participating in their own health care. And we want kids and adults going in and getting their vaccinations, and getting their checkups and whatever testing they might need to support their continued good health. And we increased medication compliance over 70% by tracking the HEDIS AMR for that. ACT scores are done regularly. Patients, it's a one-year program, and patients do an ACT once a month. And we also use a nationally accepted quality of life tool. And we run that every month too, to be sure we're actually improving their quality of life. And that's illustrated in these slides. You can see the improvement in the ACT and the improvement over the 12 months in the quality of life. So University of California, Santa Barbara's economics department did an evaluation for us on our cost effectiveness. We looked at a year pre and post program completion. And according to them, we saved the Medicaid system $3.63 for every dollar invested. I've seen a lot of different numbers over the years for this savings. Most of them come out of hospital-based clinics that are working the patients that are their patients in these clinics. Our patients are a little different group. Some of them have been to the emergency room. A lot of our patients spend a lot of time in their doctor's office instead. Their asthma is just as poorly controlled. They may have 10, 12, 15 doctor office visits a year, but because their doctors keep really good hours and are open a lot and they go to urgent care, they never see an ER or a hospital. So we tend to focus on patients working with the health plans. We are able to determine the risk that these patients face by looking at their AMR, especially their medication use ratio of controllers to rescue inhalers, and determine who's at higher risk for ending up in an ER in a hospital and preventing that visit from happening in the first place. So this drives the cost savings down because we don't have those big hospital bills to balance it again, but I think is a very reasonable number and still continues the focus on where this program belongs, on high-risk asthma patients. So the big disaster in sustainability is there's still no direct reimbursement at this time from the constructed healthcare system for this intervention. And that's hard to believe after the many, many studies that have been done over the last 20, 25 years demonstrating the cost benefits of this particular intervention, and the fact that it works, that it helps people stay at work and stay in school. But we have several things going on right now. We were lucky enough to have a state senator who passed a bill to provide $12 million for these programs across California through the Department of Healthcare Services, which is the department that grants status in the Medicaid system for reimbursement and can create what's called a new provider class. And we're pushing that there be a provider class called community health worker. And if so, then we can build a system directly. So we're engaged in that pilot right now. It's 3 years long. We're not quite a year into it. The first year will end July 30th. Unfortunately, it started August 1st, so we are going to be extending it a little longer because of COVID. And the AIM program does serve as a model in California for other asthma home visiting programs. And I believe it's the only program to have a dual partnership with managed care organizations and a county community benefit organization, which is something we were able to develop here in the last couple of years that gives us access to those county-led weatherization programs, energy efficiency programs, and SNAP and WIC and all these other programs that are so critical to helping this particular patient population. And I believe that's the end. Thank you very much for your time today. I appreciate it.
Great, Kevin. Thank you. I love the coordination and collaboration with weatherization and other Healthy Homes projects and other services that provide really integrated care. And the impressive results, a decrease of 70% in hospitalizations and an increase of 70% in medication utilization. So really impressive results for a community that needs it most. So thank you.
As well.
Next, we'll turn it over to Dr. Carstairs from Rady Children's Hospital, San Diego, to talk about their award-winning asthma program.
Thank you, Tracy, and thank you, Kevin, as well. It's always nice to meet partners in your own state that have the same passion that we have for health disparities and really specifically to asthma. So thank you, everyone, for the opportunity to speak on behalf of our organization, Rady Children's and Rady Children's Health Network. We are very honored to receive the 2021 EP Asthma Leadership Award addressing asthma disparities and health inequities and share our organization's journey with all of you and how we have dedicated ourselves to improve the care and lives of the children in our community with asthma, and also walk you through our dedicated focus that we have really taken over the last 5 to 10 years to address health equity at every opportunity for these children. So some background, Rady Children's Hospital is a large coordinated care facility. We're a freestanding children's hospital that serves over 90% of the pediatric population for specialty care in both San Diego County and our neighboring counties of Riverside and Imperial. And our typical volume is around 250,000 children every year rely on us for specialty care. And 55% of those children either have Medicaid insurance or no insurance. In the year prior to COVID, the 12 months right prior to COVID, we treated nearly 3,000 children with either moderate or severe or poorly controlled asthma who had that Medi-Cal, undocumented, or no insurance. And many of these children live in neighborhoods commonly associated with social inequities related to poverty, air quality, and other socioeconomic and cultural factors. And we know that the lifetime asthma prevalence in San Diego County is just under 11%, and that number at face value does not seem so low until you start to do a heat map like you see here. And we know that there is a wide range of socioeconomic levels throughout our county, and using these geo-mapping tools, we can really see that we have some cluster regions that we need to focus on. And this helped guide our targeted population that we try and really do intentional outreach to support. In Riverside County, one of our neighboring counties that isn't shown on this heat map, there's over a 16% prevalence of asthma for children. And then even more devastating in Imperial County, where 22% of those residents live in poverty, the overall asthma prevalence is close to 18%. So we really have a community that is in much need of our support. Our Rady Children's Health Network, which I will explain in a moment, has a prevalence of 8% for asthma. And of those with asthma, the primary population are children of Latinx and Black ethnicity and race. And we have about 50% of those children are on managed Medi-Cal as well. So a fundamental component of our program, and really any asthma program, is to appreciate that the care of asthma does not occur in the hospital. Kevin really alluded to this as well. It occurs in the home environment where these children live, which includes both the schools and their neighborhood, not just the house that they live and sleep in. And the most important place for asthma medical care to be managed is in that home, but as well in the primary care setting. Because in a perfect world, no child with asthma will ever need to seek care in an ED. I'm an emergency physician, and my dream is to say we don't see asthma in the ED. And wouldn't that be wonderful that it's managed so well with the environmental interventions in the home in partnership with the primary care physician, so that children never have to step foot into an ED or even worse, be admitted to a hospital. So when you look at your asthma programs, it's really important to acknowledge all these environments where children and families live and create a successful plan that will approach that full continuum of care with that really important insight that it doesn't occur in the hospital setting. The Rady Children's Health Network is a clinically integrated network that provides an ACO-like model of care with capitated managed care arrangements, and we cover primary, specialty, and hospital-based services. We really dedicate ourselves to the quadruple aim in all of our work. And what's really great about our clinically integrated network is it provides an opportunity for us to grow relationships and achieve alignment like we did with our asthma program and initiatives that support children. And this has been really a bright and shining star of our clinically integrated network. Through our network, like other networks, we follow all the HEDIS measures. We follow healthcare utilization, but we have a real specific focus on asthma. We look at utilization specific to asthma for the primary care physicians, the ED, the specialty clinics, the inpatient settings, and very, very closely watch that asthma medication HEDIS measure so that we know that we're doing the right thing for these kids. When we report these out, if we see something that's going in the wrong direction, we immediately take action and address where we need to intervene and help these children. We also have a really nice integrated system where we all work from the same electronic health record, which has allowed us to develop tools for the clinicians and the patients alike. So our dedication to asthma and our asthma program, as we started to write up our application, we realized we've really been doing this for a decade, if not more. And initially it was little bits, and then we built this really beautiful program that involved multiple stakeholders, including the primary care physicians, the asthma and allergy specialists who run a severe asthma clinic, the ED physicians, the inpatient physicians, and ICU physicians, and in every setting our nurses and respiratory therapists are really critical for this work. And then we've engaged with our clinical informaticists as well to build IT tools that help guide us in the right direction. To address standard of care, we've developed clinical pathways and standardized our asthma scoring system, also tailored discharge instructions for specific patients with specific types of asthma and specific needs. We have order sets and decision support tools in all areas. And this is really important because when we talk about children with asthma in our network, we all speak the same language. We use the same asthma severity score, we use the same diagnostic tools, and really look at our registries really critically to make sure that we're doing the right thing for these children. Specifically in the ED, we have done what other EDs have done, where we will actually initiate controller medications during an ED visit with guidance from our specialists and in our asthma clinic to make sure that we take this opportunity to really get these children on the right path with their asthma care. We have also initiated a really robust education program where our respiratory therapists show videos, do teach backs right there in the emergency department at every opportunity for our children who come to the ED. We recently, 5 years ago, received a TCPI CMS funded grant to look at transforming clinical practice and develop clinical guidelines to standardize the care of many pediatric common conditions. The most important one was asthma. And through this work, we were able to reach out more intentionally with our primary care teams to design education and really align all of us around the continued care for children with asthma. We underscored the importance to connect to medical homes, disseminating very age-specific and asthma diagnostic-specific guidelines. And we were able to expand on some existing relationships with the school nurses to provide asthma-specific education at our Asthma School Nurse Conference. We were really intentional engaging our patients and our families in focus groups. And then we started doing some group visits in primary care offices in low-income areas, and that's the pictures that you see here, which was really a great opportunity for these families to come together and meet each other so that they have a peer support to help their children with asthma in the homes. We've also developed many toolkits that we give to the primary care physicians to then give to the families as well. At the very end, in the last year of this grant period, we developed a robust patient callback pilot. Every child that came to either our emergency department or was admitted to the hospital would receive a call within 24 to 72 hours of this phone call to just see if they had any lingering questions, to make sure they understood their asthma action plan and treatment plan, and to ensure compliance with that. We would also ensure that they were connected to their medical home, provide directions to pharmacies if they needed a prescription filled, and then we would offer an RT telemedicine visit if they just needed some help learning how to use their inhalers. So it was a really robust program that we took advantage of through the TCPI grant. We've addressed the environment knowing that, it seems obvious that where children with asthma live, that you should take an intentional approach. But I think in healthcare, sometimes we just ask those quick questions, right? Do you have a cat? Do you have a dog? And then you move on. But now that we know that we can go into the home, whether it's in person or during COVID virtually, that I'll talk about in a moment, we've been very intentional about providing those services in the home with our CASA program and our ED call program to really make sure that we go to that next level to help define needs on an individual basis and then design interventions. Our health equity lens is something over the last few years we really started to look at more specifically. As I showed you with the heat map, we also are developing a health equity dashboard to make sure that we aren't just addressing where they live, but looking at the social determinants of health that are influencing their lives, things like food insecurity, housing insecurity, and other programs that may not typically be found in a healthcare environment, but certainly influence children with asthma and other social disparities. So now I want to share some specific information about our programs. So this is the CASA program. And our CASA program has been in existence for well over 5 years, but most recently, thankfully, was funded by Cigna as one of our partner health plans to really expand and grow this program. We've also been augmented by the Cliff Family Foundation and Rabbit Air to allow us to expand providing more resources to these children and families with asthma. The overall goal was to improve asthma management for children with severe childhood asthma. Any child aged 2 to 18 with more than 2 asthma-related visits or any admission to the hospital is referred into this program as well as referred into our severe asthma clinic. What this program does is it utilizes a community health worker model. The community health workers will contact the family. They'll in-home visits or virtual, as we did in COVID, and and they'll target the families to conduct really extensive environmental assessments. And then the next step after those assessments is to provide home remediation tools and supplies. There's a standard kit that they all receive, but some of these families just need a little bit more. For example, they all receive cleaning kits and air purifiers, but they may need more than one pillowcase, for example. Maybe there is a shared custody situation for these children. So we can really get to the heart of where these children live and play and make sure that we provide every resource that we can. We took it another step further through the social determinants screening, that if these families had an indication that they might benefit from a 211 referral, we did provide that referral to them as well. And 211 is a local nonprofit organization. Many of you have this in your community that helps them access multiple community health and social support systems. They have navigators that will really proactively contact these families and implement a custom risk score to make sure that we're evaluating all the domains that influence someone's social challenges, of which there are actually 14. These community healthcare workers serve as a part of our integrated care delivery team, working very closely under the supervision of a physician and a social worker to make sure that everything that needs to be addressed is addressed. During COVID, we were just about to launch the next phase, and of course, like all of us, COVID changed everything. So we rapidly transitioned to a virtual home visit, which, believe it or not, actually allowed us to engage with more families and children. We're not really sure exactly why, but more opted into the program. Maybe they felt like it was a little bit less intrusive. It was more convenient. We could do it at any time of the day. And we did this, thankfully, through our existing telemedicine program and our electronic health record here at Rady Children. So there wasn't a whole lot to change with respect to how we implement it in the IT world. But it's been really beautiful because more children now are able to take advantage of this environmental screening. Any family that had an indication, if they hadn't been seen in the severe asthma clinic, were connected, and then we continue to offer them visits to the severe asthma clinic for a multidisciplinary approach with both an allergist, a pulmonologist, a pharmacist, a respiratory therapist, and of course the important nurse coordinator function. They all received asthma therapy assessment questionnaires as a follow-up assessment as well. Our next program that's really a more recent addition to our program is through sponsorship with HealthNet. We've been able to develop a health equity dashboard. The objective of this program is to do some of that geo-mapping that I showed you earlier. But now that we've identified it, build those partnerships in the community with the schools and make sure that we are getting the resources to these targeted communities that will help improve the outcomes of asthma. We've developed a health equity index that will capture children with asthma seen both in our ED and admitted, and complete all social determinant screening for transportation, food insecurity, homelessness, or any exposure to smoking. And then we offer resources after that. For example, if the parents smoke, we will connect them to our quit line here in the community to help them obtain resources to quit smoking. We also attempt to make sure that our highest risk patients, anyone that was seen in the ED, which is oftentimes about 30 a week, that we continue to underscore any support and offer the resources within the community through 211 or other resource partnerships that we have to address their transportation struggles, food insecurity, or any homelessness or legal issues. So this is my favorite part of our program. So what's really great is we get feedback from these families. We call them again, 211 calls them again. So this is a slide that really speaks to the testimonials we've received from families. They comment on the importance of the air purifiers, the cleaning kits, the connections to 211 to help them potentially with some of the food insecurities or legal issues they may be struggling. As you all know, San Diego is a border town, and we have a lot of families who sometimes are reluctant to seek care for their children because of their status as an immigrant. And so many of those obstacles we can remove through the 211 connection as well as through using our telehealth services. My favorite here is a comment that we just recently received from a mother when her child was seen in the severe asthma clinic, where she said, you know what, my kid gets to be a normal kid again. And it's really touching because that's what we want for all children, right? To feel like a normal kid again, dance, do gymnastics, and not feel like asthma is limiting them in any way. So on this next slide, you will see that these are some of our results. So we're often asked about the ROI our investments. As I said, we are a capitated Medi-Cal managed care health plan, so we track healthcare costs and utilization for our network patients, but we don't just stop there. We look at all the patients in our community. So here you can see results from our callback pilot that was funded through our TCPI grant to show that just having that connection, offering that additional teach back opportunity, additional questions to be asked after what may have been a stressful ED visit or inpatient admission we can reduce healthcare utilization. And so when you look at this, the overall is the green line. The red is our Medicaid population, and the blue is our commercial population. And what I like about this slide is that the reduction of 7-day return visits, we're almost achieving health equity here, meaning that those children with both Medicaid and commercial insurance are, for the first time after these interventions, really close to each other. And if you look really closely to our Medicaid population that hadn't had an intervention with a phone call, had close to a 14% 30-day return rate, and we reduced that down to 8%. So we're really proud of this, and it really just underscores that need for that continual connection in the home and the environment where these children live. We were able to contact 800 children successfully. 21% of them actually needed an additional RT visit. They all received RT intervention in the ED, but again, this can kind of be a stressful environment in the ED. It was an unexpected visit. The child was very sick. It really shows the importance of that IT intervention. And 87% of them said, we understand things better because you called us. And 84% felt like they were better prepared to manage their children's asthma in the home after these phone calls. So the next slide shows our results from our CASA program in partnership with 211. So of the families we contacted, 24 of them opted in for 211 support. Of these 24 families, 264 different community referrals were made. And what's profound about that is if you think about the needs of these families, that 24 families needed 264 community resources. That speaks to the need to help for the social inequities and really screen for social determinants of these children and families. 92% of those families experienced a decreased vulnerability score from the 211 assessment in at least one domain. And so this graph really shows that there is so much more that influences a child's life than just their disease. And by improving basic needs and intervening on things like food insecurity, legal challenges, housing support, not only do we improve the life of the child, but we improve the life of the family and their community that they live in. So lastly, the questions always are, how do you sustain a program like this? Well, one area is to continue to address the team that's needed for these outcomes through things like annual budgeting. We're always applying for grants and talking to our philanthropic partners around philanthropic gifts, as well as advocacy at the state government level about the importance of these types of services being a covered benefit for both Medicaid beneficiaries, but also commercial plans. If you can reduce ED visits and admissions and control asthma well, the most important thing is improving that health of the child. But from the health plan's perspective, the ROI on this is phenomenal, as you saw in some of Kevin's analysis as well. This is really an investment worth making. Our asthma program is also is really an area of pride and commitment as an organization. We talk about it. We generate enthusiasm around it, and that's the culture of supporting asthma that we've really created. We developed strategic partnerships, as I told you earlier, with 211, HealthNet, Cigna, Rabbit Air, and the Quick Bar Foundation continue to really be champions of our work and help us support us with some of the financial needs to support that home remediation. And really with a dedication to addressing that environment where children with asthma live and looking for any opportunity to educate the families on how important it is to have a home, school, and social environment that supports their child with asthma. We know that if you invest in that early, like any other early child intervention, you can really have an impact on not only, again, these families, but the children and the community that they live in. Also, really important for us in a pediatric setting to make sure we're preparing children to transition into adulthood, and those with a chronic condition, if you intervene early and teach them about the important environmental interventions as well as the management of their disease, they'll transition much more smoothly. So the only other piece of advice I would give you is going through the process to apply for this award was really a celebration for us, but it also helped us to find gaps and next steps and interventions that we need to take. So I hope all of you will consider applying for the award and at the very least sitting down and really just writing out what you've done and what you want to do, because you will gain a lot from seeing that all in writing and putting all of your pieces together. It's given us a phenomenal perspective of where we started, how far we've come, and where we need to go next.
Thank you so much, Dr. Carstairs. Incredible program, incredible results. I loved your consistency. You talked about making sure everyone's speaking the same language across the continuum of care. I loved your community outreach involving the schools and school nurses, and the health plan, healthcare provider with Cigna, your partnership with Cigna. Really great components, a really incredible program. So again, congratulations for the award and for all the work and the difference you're making in your community. So with that, that concludes the presentations we have today. We do have a polling question to end here. Based on today's presentation, we want to kind of hear what you think, how you'd like to get into action, and what you feel more equipped to do with your own asthma program. So what you heard from our award winners, has this given you ideas to approach new community partners? Are you providing virtual visits? Do you need help with pivoting to do that? Are you considering refining some of your tracking to show maybe return on investment data like we heard from our award winners? If you're not already a member of Asthma Community Network, that's actually not on there, but are you going to request a mentor? We talked about the mentorship program. And again, we'd love to hear if this has encouraged you or inspired you to apply for next year's award. So let's just take a moment and let folks answer the poll. Great. So half of you are thinking about approaching new community partners. Incredible. Data is so important, and tracking our outcomes. So 20% said they're looking to refine that. Please request a mentor. These programs have so much information and a wealth of experience to share. And we look forward to receiving those applications for the 2022 Asthma Award. Typically, the application opens in the fall, late fall, around November timeframe. We open through January, and then the award winners are announced to kick off Asthma Awareness Month in May. And you may be featured next year on this webinar. So please consider applying, and thank you to Dr. Carstairs for her reflections on how applying for the award actually helped them kind of realize the components of their program once they put it on paper, and how they've evolved and the good work that they've done over the years. So with that, we're a few minutes early, but that just gives you time to go over to the question and answer portion on AsthmaCommunityNetwork.org. Here are the instructions again. You're going to look for the tab under Connect, the discussion forum that will have today's date, and then you're able to click on that link and submit your questions. And our two speakers will be answering in real time. So if you're able to share the next half an hour with us, we encourage you to do so. Or check back if you submit a question and are not able to stay with us online. Check, and your answers will be archived there. Thank you again. Congratulations to both Central California Asthma Collaborative and to Rady Children's Hospital San Diego. And thank you all for being here today. That concludes our webinar.